it for you. How are you doing today?
I'm good, man. How you been?
Not too bad, not too bad.
Busy day?
Yeah, a little bit.
Yeah.
It's Monday, so... Come forward, check out the height for you.
Yeah, it's fine.
Okay. So always focus on the black circle in the middle. Okay, take a couple of blinks. And now keep your eyes nice and wide and try not to blink. Okay, you can rest back. Okay, and now to your left eye. Okay, and again a couple of blinks. And nice and wide now, try not to blink. Okay, you can rest back. Okay, you can rest back. If you just hold the next one here.
There, yeah.
Okay, come forward. Into this one, just focus on the hot air balloon. Okay, now same for your left eye. Okay, you can rest back. Okay, just move the glass from here. Thank you. Okay, come forward. So you're gonna check your eye pressures. I'm gonna put a light puff of air in here, okay? Look straight ahead. Okay, just one more time. Now same for your left eye. Okay, take a couple of blinks. And now keep it nice and wide. Okay, you can rest back. Just move back to this one. Just gonna try to do your eye pressure from this one, okay?
We can't get in the other one now.
Say again?
You can't get in the other one.
Yeah, we're gonna try to do your left eye on this machine, okay? Okay, look straight ahead. Okay, and one more time. And take a couple of blinks. Now open it as wide as you can. Okay, just one last time. As wide as you can. Then you can rest back. Just follow me this way, just want to do one more, okay?
Okay.
Just put your seat in the floor back there.
Okay.
Okay, how's the height here?
Yeah.
Okay, look straight ahead. And take a couple blinks. And nice and wide now. Try not to blink. Okay, you can blink as normal. Okay, I'm gonna move to your left eye. Okay, I can look straight ahead. And take a couple of blinks. And nice and wide now. Nice and wide. Okay, you can rest. Okay, then it should be all done.
Yeah?
Yeah, just continue waiting back in waiting area for now.
Okay, perfect. Thank you.
Thank you.
As well?
No.
No, okay.
No.
Okay. So you saw already Stephanie. Okay. So who told you you have an eye condition then? Keratoconus. Someone mentioned to you that.
Yeah, originally, so when I got my eye tested originally at my workplace,
Mm-hmm.
then when I went to the hospital,
Mm.
then they told me.
Mm-hmm.
They said at first they said it's quite mild,
Mm-hmm.
and then obviously as time went on, the only issue with that was obviously Windsor kept cancelling my appointments,
Yes.
discharging me, things
Yeah.
like that.
Yeah. Okay. So it's interesting. So this is your prescription,
Yeah.
and just a quick look at them, we can find or see that your left eye in particular,
Yeah.
from being a little bit short-sighted, something very mild, you
Yeah.
still got good vision, from 2015, 17 suddenly developed astigmatism, that's the eye becoming suddenly changing the shape,
Okay.
and that is, this is same, what is 19, even worse, so
Yeah.
so it's by just looking at the prescription, you have something changing your eyes,
Yeah.
which doesn't fit with your normal. We all have a bit of myopia or short-sightedness. You progress a little bit, but this is too much,
Oh, okay.
and it's not the prescription we normally expect to progress. So that comes from the cornea becoming abnormal. That's the cornea, that's from the window of the eye. And this is that. So this is just the other records.
Yeah.
Okay, fine. So what I'm gonna do, I'm gonna have a look at the eye and then discuss the scans with you, because it's very
Okay.
interesting scans. So let's do that. All right,
Okay.
good. There we go. Okay, so I'm gonna show you bright lights. I'll just keep your chair a bit. Excellent. Right, if you just look straight at my ear there. Excellent. Very good. So we have all the thinning, I can see it on the cornea here, and there is that iron line, the
Okay.
brown line, that's
Yeah.
show me where the cone is, that's
Yeah.
where the cornea is, funny shape.
So right in the middle.
Yeah, exactly. I'll show you on the scans,
Okay.
more pretty on the image on the scan. You can just see that it's very dry on the bottom. Do you sleep with open eyes? Anyone commented your eyes?
Yeah.
You do, right?
Yeah, a lot of people say I sleep with my eyes open.
Here we go.
Yeah.
So we need to do something about it. I don't know, do you take any drops, anything?
Yeah, I've been using drops every single day.
Okay.
I've been doing the heat compressors,
Okay.
the wipes.
Okay. But do you put anything when you go to bed?
No, I put the drops in the night
Yeah.
before I go
So
to
we need,
sleep.
yeah, that we'll discuss that, but something need to be put like a gel or something to protect the eye when you go to bed. Because if your eye don't fully close, then there are exposure here,
Oh, okay.
and that means your eye dry out over the night. Look up for me, just a couple tiny drop there. And there. Good. Blink a few times for me. Excellent. Right, let's see. So that's the fluorescein staining. Blink, blink. Obviously, the bottom part of the cornea is very dry.
I've been using the night gel every night.
Okay. So you stop that now or
No,
No.
I've still been using
Okay.
that.
So,
I've been doing the heat mask.
so the tea break up time definitely reduced. By the time you blink again, it's not even 2-3 seconds. It starts to break down. And I'm just gonna test those glands
Okay.
because that's the dynamic assessment.
Yeah.
Press the glands, see what's coming out of them. If you look up for me, please. Good. It's quite thick oil here, but there's not much of in terms of obstruction. So the glands flowing, but the oil, not all of it, like nice and clear. Some glands bring very thick oil. That can be improved. Okay, good. I'm just gonna check the back of the eye.
Yeah.
Just check the nerve and the retina is healthy. So just look straight at my ear. Good man. Good. Okay, to my other ear. Thank you. So anyone in the family with any eye disease at all?
My uncle had very mild cataract, my mum's brother.
Okay.
But other than that, no, everyone in my family's got really
Okay.
good vision.
Good. And you get atopy, so you get asthma, eczema,
Yeah.
hay fever, so the three of all of them, right?
Yeah.
Fantastic. Okay. And who's supervising your gland disease and the dry eye disease? Has
As in-
anyone in the general treatment, monitoring all that?
I've got because I work at Spectators as well.
Okay.
I've
Okay.
got the optometrist
So
that they check it or
they check
literally
it. Okay.
every single day they
That's
check
fine.
it.
That's fine. Okay.
Yeah.
So I mean, clinically, examining the eye, obviously you have keratoconus signs, at least in the left eye,
Yeah.
but you know it's in both eyes. In my view, keratoconus always affects both eyes.
Yeah.
I don't remember seeing one eye, and if it's not showing up now, there's usually 2-3 years difference between the two eyes.
Oh, I see.
So whatever the left eye got by now, if you were 3 years, the right eye
Right,
will
I'll be
follow.
the same, yeah.
But it's interesting scan, which I'll show you now.
Yeah.
Are you familiar with cornea tomography? Do you know what's that?
No.
Okay, so this is a scan, very detailed. Take hundreds of points on the cornea, front, back, etc.
Yeah.
Measure the shape of the cornea, the thickness of the cornea, the profile of the cornea, everything. And really, really sensitive to detect very early changes in the cornea. So when we look at your right eye, first of all, to be honest, looks fine to me. Very little changes, but nothing really to say you have keratoconus, for example, right?
Yeah.
So here, this is the shape of the cornea front and the back.
Yeah.
This is if you have any astigmatism.
Oh, okay.
This is if you have thinning of the cornea, and even the K-max, which is the steepest point of the cornea.
Okay,
because
yeah.
with the keratoconus, you're going to become steep and thin.
Yeah.
It's not too steep.
Oh, okay.
So one look at this, and even we have something called indices. These are keratoconus indices. So tell me if there's any signs of irregularity of the cornea.
Oh, okay.
They all look normal, right?
So that's
Which
good.
is a good sign.
Yeah.
So based on this scan, one might say, actually, your cornea is fine. There's a little bit of changes on this. It's called Billion Ambrosio. This one, look again at the regularity. So you are borderline changes on the right eye,
Oh, okay.
but nothing tell me you have keratoconus. While the left one, if you look at the left one, it's more obvious. So on the left one, we have the cone here. That's
Yeah.
a very steep area on the cornea, and the same area is thin.
Yeah.
And actually, when you look, there's the indentation on the cornea front and the back.
Yeah.
So the cornea actually is like a small cone bulging forward.
Oh, okay.
That exactly happened. Now, the interesting thing that one, your right eye vision is excellent, which
Yeah.
is good. Left eye vision is reduced.
Okay.
And when I say left eye vision, you will ask me, but I have the condition in my left eye, but the vision is not badly affected as much as one would think. Despite the keratoconus here is quite advanced, to be honest. And the reason for that, simply because your pupil is here.
Yeah.
So actually, there's not much happening around the pupil area, but all the cones sitting below the
okay.
pupil. And that's important to know because I'm going to discuss with you in a minute options of management plan. And look here, all the indices are red.
Oh,
It's
okay,
obvious
yeah.
that actually this cornea is very abnormal.
Yeah.
And even this Billion Ambrosio is bad. It's
Yeah.
just quite very high actually, it's 10. So there's left eye, no question, this is keratoconus. But as I said, in the right eye, when we've done it, nobody will tell they have a keratoconus on the scan. But this is interesting. This is called the cornea thickness map, and we
Yeah.
measure the epithelium thickness as well.
Okay.
And this is actually a very interesting case here. That's why I told this is
Yeah.
you're not a usual case.
Okay.
Because when I look at the right, this is your right eye,
Yeah.
and this is your left eye. Let's look at the bad eye. So it's very obvious changes.
Yeah, you can tell.
Left eye, this is the epithelium. So the cornea has 5 layers.
Okay.
The top, the skin called the epithelium, and that epithelium is like the plaster on the wall. So it really masks all the
okay.
changes. So when your cornea start to thin and bulge, what happened? The skin start to thin a little bit to compensate for that cone.
Oh,
So,
okay.
so thicken it outside and on the cone it's very thin,
Thin,
plastering. And that is very thin. The blue are thin, very thick. So
Oh.
above the cone, you got very thick skin,
But
and
then
below it, actually,
very
the
thin.
cone is thin.
Okay.
When you look now to this eye, suddenly you find, if I don't see the other scan, I would say this is abnormal,
Yeah.
and I would say, look, this is the right eye, this is which the topography showed is a normal scan.
Yeah.
Right eye is not normal here because you can see how the skin here is thickened,
Yeah.
and here it's thinner than this.
Yeah.
So comparison, there's something happening here, and that's where we talk about sometimes the epithelium maps actually can detect early keratoconus,
Oh.
and that is very
Yeah, because
important.
last
in
time I
those
went to Windsor,
cases.
they done it,
Mm.
and they did say it looks like you got very, very mild in your right eye. but
Yes,
It's very.
Yeah. So based on that, you have keratoconus in both eyes,
Okay.
and I have no doubt that the right eye will progress as well.
Okay.
I hope I'm wrong, but
Yeah.
by the train, by the stats,
Yeah,
by all that,
You know.
clinically we've seen cases where the right eye or left eye, which is a milder one, will follow up after
Oh,
a few
okay.
years, and then they will progress. So, treatment-wise, first of all, there's two things of treatment. One is to stabilize the condition. We don't want the keratoconus to progress. By nature, by definition, it's progressive thinning
Yeah.
and bulging of the cornea. We want to stop this process. And treatment is very simple. It's called cornea cross-linking.
Hmm.
So this is exposing the cornea to UV light.
Okay.
So they found actually you can induce a bit of reaction in the cornea to allow the layers in the cornea. The cornea is like a stack of layers of what we call collagen sitting parallel to each other.
Yeah.
The cross-linking or the UV light help to make bonding between those layers, so the
Oh,
cornea
okay.
become compact,
Yeah.
and that's make it stronger. So what you try to do with cross-linking is try to stiffen the cornea,
Yeah.
because the cornea is very elastic, it's called it, and it's stretching too much. So to thicken it, not thicken it, make it a bit stiffer,
Yeah.
and that's what cross-linking. And the treatment is simple. It's approved by NICE, which is body advice on clinical procedure, safety, efficacy, etc. So NICE said keratoconus treated with cross-linking. Cross-linking is effective. It works.
Yeah.
Not 100% of the time. There are various statistics, but most in your case, I would say 90% it will work.
Yeah.
10% it fails. Meaning that your cornea continue to progress.
Okay.
It's not going to progress straight away. That
Well,
takes
take
years.
time. Yeah.
So we're talking about like looking at 5-10 years, what's gonna happen? 10% chance to regress or fail, so it's good, the keratoconus continue to progress.
Yeah.
In that case, we can treat again. So it's not
Yeah,
like you
that's
lost
the thing.
it.
We had a few people come into my work and they've got keratoconus. We've got a lot
Yes.
of people,
Uh-huh.
and they said the same thing. Like, yeah, we've got it all done,
Yeah,
and then years down the line, the vision just gets worse.
it's true. There's another reason why it fails. So remember, same treatments, cross-linking is the name of the treatment,
Okay.
but there are small details. The machine used,
Oh, okay.
what treatment zone they treated, so that makes difference between some kids. If you not irradiate the cornea the best way and with the right tool, then obviously it doesn't work so well,
Yeah.
right? So there's small things, details.
Okay.
But let's say we have the best machine, which we do here, we have everything as should be.
Yeah.
What the chance to work? 90%. 10%, it does not work, they need another treatment.
No, true.
And that usually, if it shows the 2-3 years, you know it's not
Oh, I
working.
see. Okay.
The second question is about, do we treat both eyes on one eye? Left eye definitely, I don't think we should sit and wait till you use more vision, because already at a critical stage
Mhm.
where actually a bit more progression, that one I showed you, if it's got a bit worse,
Oh, I see.
you're gonna lose the vision a lot.
Yeah.
And usually the loss of vision go from you losing vision gradually. Once the cone cross the pupil,
It's gonna
your vision drop.
completely. Yeah.
Then suddenly you find, oh my god, this is too much. That is usually what makes people come to see someone.
Okay.
Doctors or something. The real question is about the right eye. So the left eye we said is advanced already, we need to treat it, we can't wait. The right eye, shall we treat or not? Because the right eye have a good vision. Now we go back to NICE, what it says, it's effective, good, but what side effects? Because in any
Yeah.
procedure you have to think, okay, I have a benefit risk, I want the balance. If there's a good benefits and little risk,
risk,
then you
yeah.
might justify. So NICE said there is a risk of infection and scar or haze on the cornea.
Okay.
Any procedure got infection. Haze mean that actually, imagine you go to the beach, you're going to a suntan, then you got burn.
Yeah.
The same happened with UV light. It's baking your cornea.
Oh, okay.
So it's sometimes the cornea react by having a scar because it's burned.
Yeah.
if that happened, proven throughout the follow-up, obviously there are treatment to minimize the damage, etc. But that's still a risk.
Yeah.
So risk around 1 in 500 to have infection or a scar or haze on the cornea. I don't have any patient lost their vision or cornea from bad haze or bad infection, but risk is risk.
Yeah.
There are cases where, I'm talking about patients, your age group, category, etc. There are cases where there's more risk of infection, but we're not talking about those now.
Okay.
So the right eye, I'll say in summary, I would recommend reading treatment for the right eye because I want to keep your vision 6/6. I want to maintain that eye. So your option either do nothing, but then we have to monitor every 6 months, repeat the scans, or go for cross-linking and then that's it. We still monitor obviously, but if you don't cross-link the right eye, I think we must keep an eye, very close observation, because this is your good eye, and you trust me, you get upset when the vision starts to drop in the good
that's
eye.
what we're noticing recently, right now, especially recently, because I'm so used to it, it's normal, but then I've been noticing a lot that I can't see.
Yes. Usually patients like yourself, when they have keratoconus in one eye, they don't notice it because the other eye doing a good job. When the good eye start to be affected, and usually early signs you see a little doubling, shadowing, tail to the letters, all the things make you say, okay, this is not right. So you start to lose the contrast and the sharpness of letters, and that's where it all starts a little bit. So that we talked about cross-linking to stabilize the condition.
Yeah.
Now the second question is about corneal rings, right?
Okay.
What corneal rings? So if there is a way to increase the potential of vision by improving the funny irregularities in the cornea, then that means that we do something to make you able to see better by other modalities.
Okay.
This is called corneal rings. So these are basically implant segments you put inside the cornea, like to make the structure more regular. The cornea is funny irregular. We put those 2 segments or 3, or even sometimes we do 1 large segment, and then reshape the cornea. So we try to stretch the cornea, make it more regular shape. Very good way to do it, but there is more risk in rings because you're putting plastic inside the eye. So that's why we have two things. One, is it how likely is it to work? And 2, the complication or side effects. Now I have a concern about the rings in your left eye is your cone, as I showed you, is sitting below the pupil. The rings might shift the things, so might shift the cone actually up a little bit because it tries to make things more regular. By that shifting, if that cone become in front of the pupil, you're gonna find your vision dropped. So you go for rings and then you find your vision dropped. Not necessarily drop that cannot be corrected, might still be corrected, but to be honest, it might give you a much higher prescription. So example, if you have -3 now, you might find actually suddenly you're -6, -7, because actually we move the steepness from to the center. And plus, depends how the cone will move. If it partially moves and not fully moved, then you get more astigmatism, and then so there is a little bit of unpredictability here of what happens with the ring. If your vision is worse than that, because your vision in the left eye 620, we can improve with the glass 610. If the vision worse than that, like 612 and less, I would say, yeah, we can do something because I want to improve the potential of vision. But as it stands, I'm less excited about putting ring inside the left eye. So again, option for the left eye to improve the regularity, either option 1, no rings, or option 2, put rings but accept there is a risk that actually the prescription will be completely different, potential of vision might be different, we can't guarantee it's going to be much better, so there's a lot of variabilities. But if you want to improve your vision in the left eye, then we can have something called ICL, which is implant inside the eye, implantable columnar lens or contact lens. These are work to give you the vision you get with your glasses. It's not going to give you extra. Also, some patients do 20% get a line extra, but that's not the guarantee here. The thing is, we can get you to 610 with ICL safely because actually, once we're happy the cornea is stable, then all the matter is check prescription, put lens implant inside the eye, fix that prescription. And remember, sometimes the cross-linking itself could change the shape of the cornea. You might find some improvement in the vision anyway. Again, that in 30% of my patients, they get a little bit of a line or 2 improvement after the cross-linking because you flatten the cornea a little bit. So based on that, I would say I would rather you don't rush into anything in the left eye more than just cross-linking, stabilizing. One thing stable,
Yeah.
maybe a year, then we can measure the eye, the left eye, and that time your choice. If you feel like, okay, I'm improved with the glasses to a satisfactory level, can I have ICL to fix my prescription, then you can have it. Because remember, developing funny prescription, high end and almost very low prescription, sometimes you don't like that. Your brain can be confused, you can start get doubling, etc. So, but that is really have to wait to do the cross-linking and then see where you end up, and then that's another thing about it.
Okay. And then I have to wear glasses after I get the cross-linking done.
Yes, until things stabilize, then we decide. If you don't want the glasses, we do ICL.
Okay. And you recommend to get the cross-linking done
Definitely.
and then wait a year
Yes.
to see
yeah.
whether.
Yeah. With waiting, if you want to be 100% sure whether the cornea stabilizes, you need a year.
Okay.
I mean, most corneas by 6 months, 9 months, they kind of fixed. We know what they look
So
like.
with the cross-linking,
But we need to get a lot more stability. Yeah.
so with the cross-linking, would it improve the vision?
As I said, it's not meant to improve the vision,
Okay.
but because it's flat in the cornea, you see that's a lot of red on the map.
Yeah.
Because it's flat in the cornea a bit, some patients feel there's improvement, and we get
okay.
like 30% of patients get that one line or two. Even your prescription might change after the cross-linking.
Yeah.
That's why there's no point I can go now and do
Yeah,
ICL and the prescription change after a year.
Yeah.
And that's why we wait as well for the cornea to stabilize.
Oh, okay. There's the option.
The cornea is it's unpredictable. One is the structure of the cornea is not strong enough.
Strong enough, yeah.
So whatever you treat with laser might not maintain it,
I
you
see.
might lose it. But the last say 5-6 years there's been a lot of work to say, okay, can we do limited laser on the cornea? Because if you do cross-linking and you feel the cornea kind of stable now, why don't you do a little top-up laser on the cornea?
Okay.
Yes, and we can do that. That's called
Okay.
topo-guided laser treatment, but you have a limitation. So, for example, you can't take more than 50 micron of the cornea tissue.
Oh, I
so
see.
there are very strict criteria, and we still have to monitor carefully, make sure the cornea doesn't suddenly become unstable,
And
etc.
that would improve the vision.
That improves the vision. Yes.
Oh, it's just only the left eye. You wouldn't be touching the right eye,
No,
would you?
no. Left
Okay.
eye, to be honest, as it is very good. I don't need to touch it.
Yeah.
Except the cross-linking we talked about,
Yeah.
stabilizing. Yeah, but I'm talking about refractive procedures to make the vision better,
There's no point.
or no, not for the right eye.
Okay.